Today, a palliative care nurse is visiting Bob for an assessment. This visit is in response to a phone call by his wife Maisie, who is also his main carer.
Maisie, it's Kathy. We got your call.
Bob is a 55-year-old gentleman who has been diagnosed with advanced lung cancer and bony metastases. Until now, Maisie has cared for all of Bob's needs, and for the past few visits, the palliative care phase has been assessed as stable. But at the time of Maisie's recent phone call, it was obvious that she was distressed and added that she too was becoming unwell. Maisie has asked to talk to someone regarding Bob's ongoing care. During this visit, the nurse will establish that Bob will accept inpatient care for a short period of time to allow Maisie some respite. From discussion with Maisie and assessment of Bob, the palliative care phase has changed from stable to unstable. This is due to the urgency of needing to change Bob's management plan, as Maisie is no longer able to provide care, and Bob is experiencing periods of increasing pain due to bony mets.
Maisie, I've had a chat to Bob, and I think probably the best thing might be if we put him into hospital for a little while, give you a chance to feel a bit better. Otherwise, it's too hard for you to look after him if you're not feeling well yourself.
Will it be for long?
No, it won't be for long. We'll get him home as soon as we can.
Okay.
All right?
All right.
I'll talk to Dr. Brown and we'll see whether there's a bed and when we can get him in. So you go and have your coffee and I'll be with you in a few minutes.
Thank
All
you.
right?
Thanks.
Okay. Dr. Brown, it's Kathy from the Community Palliative Care Service here. I'm with Mr. Bob Jones and I've done an assessment on him and I think he really needs to come in to you. Yeah, he's a 55-year-old gentleman with lung cancer and he's got bony mets. His palliative care phase at the moment's unstable due to his periods of pain, and his wife's currently unwell and she's not able to look after him due to her physical and psychological and emotional state. His RUG score's increased from 12 to 16. He requires the assistance of one person in a walking frame to get to and from the toilet and to mobilise, and Maisie's had difficulty assisting him with toileting and bed transfers. His palliative care problem severity score for pain and other symptoms is moderate. However, for both psychological, spiritual and family and carer, it's severe and requires a review of his analgesic. Okay, so do you think you might be able to have a bed for him soon? Today? That's perfect, thank you. I'll let Maisie know. Okay? Thank you, Dr. Brown.
The nurse has demonstrated how the Pcoc assessments provide a common language which is translatable in any setting of care. The community episode of care will end as Bob will now be admitted to an inpatient palliative care unit and will start an inpatient or overnight admitted episode of care. An episode of care is based on setting of care. Bob is now in the inpatient unit, where the nurse and doctor will continue to assess Bob's condition.
So Kate, Bob still has a few moderate symptoms, fatigue, pain, shortness of breath, nausea, loss of appetite, and he's also having 5 fractions of radiotherapy for those painful bony metastases.
I'm just about to go and do a comprehensive assessment. Perhaps we could have a chat about his treatment plan when I've finished.
All right, catch up with you then.
The Pcoc patient is assessed using 5 validated tools. The phase tool describes the stage of the patient's illness. The phase assessment is holistic and views the patient and family as one unit. Phases may or may not be sequential, and a patient may move back and forth between stable, unstable, deteriorating, and in some situations, the terminal phase. The Resource Utilisation Group Activities of Daily Living is a 4-item scale, measuring motor function with activities of daily living, bed mobility, toileting, transfers and eating. This tool provides a total score of the assistance required due to the patient's functional status. A score of 4 indicates no assistance required, and a maximum score of 18 indicates assistance of 2 persons. The Palliative Care Problem Severity Score is a clinician-rated screening tool to assess the overall palliative care distress covering 4 domains. 1. Pain. 2. Other symptoms. 3. Psychological and spiritual problems. And 4. The family carer problems. The score is determined based on the overall distress within each domain, with 0 for absent, 1 for mild, 2 for moderate, and 3 for severe. The Australian Modified Karnofsky rates the patient's performance status according to their activity, work, and self-care. The performance score is from 0 to 100, with 100 indicating no evidence of disease and 10 moribund. Once the patient has died, no Karnofsky scores are recorded. The Symptom Assessment Score is a patient-rated tool which measures the distress of 7 key palliative care symptoms from the patient's perspective: insomnia, appetite, nausea, bowels, breathing, fatigue, and pain. If the patient is unable to do their own rating, the symptoms are rated by a proxy. These scores should reflect interventions required. For example, a patient who is in the terminal phase and not eating will not be distressed due to appetite, and therefore no interventions are planned. Therefore, a score of 0 would reflect this. Routine use of these assessment tools in practice has resulted in enhancements to the service provided by palliative care. Within this sector, Pcoc is achieving positive changes in clinical and cultural practice. Multidisciplinary team meetings are more effective and efficient using the common language that Pcoc provides. An example is using the unstable phase as a guide for prioritizing the order of patients to be discussed. Using the Pcoc assessment tools as shorthand in communication reduces the time in clinical handover and meetings. These tools can also be used in triage and assist to prioritize response times. The RUG is an effective and objective tool for determining nursing resource allocation for the next shift. For example, the use of hoists and additional staff. The PSS score is a useful tool for social work to undertake a more in-depth assessment to monitor the psychosocial aspects and what's happening with the family. In the case of Bob and Maisie, the phase change to stable and reduction in the problem severity and SAS scores were the trigger for a case conference.
Mr. Bob Jones in room 2, now ready for discharge. Can you let me know where we're at with his planning?
Well, his phase is stable now. So, Kate, I was wondering if you could organise a family conference about discharge.
Absolutely. And in relation to his symptoms, the current treatment plan has worked really well, and that's been reflected in an improvement in his problem severity scores as well as his symptom assessment scores.
And Maisie, how's she managing?
She's well rested and looking forward to Bob coming home. I've spoken to the GP and the community nurse, and they're ready to offer support when he's discharged.
Great. Excellent.
Pcoc can be used in discharge planning. For example, when staff contacts community services to reinstate his care, they will provide his Pcoc information, which gives a snapshot picture of his care status and what he needs as he starts a new episode. This is also a useful tool for any clinic or outpatient appointments. Community services have the ability to review a patient using the routine outcome measures, either face-to-face or over the telephone. This production was